Good afternoon, everybody. Today we are meeting to talk about COVID, especially the latest updates, especially what works and what doesn't work. Because there's so much of information in the last 1 year, we're really not sure which really works and which doesn't. So in the next 20 minutes, I'll go through some data. Initially, we'll give a sum up and go through some data. Like I'll rather confuse you for 10-15 minutes, and then we'll summarize finally. So I'll start with a summary. The only thing which really makes a difference is oxygen. Oxygen saves lives and use it judiciously. So the take home point is there is no miracle cure or miracle drug for coronavirus. We have several drugs, but none of them is the magic pill which saves it. With regards to certain things which may work, one is antivirals, remdesivir may have a marginal role, but this happens only in the viremic phase. Then comes anti-inflammatory drugs. Steroids may have a role. Remember I put minor. Among the things, this is some role is probably there only for steroids. Again, only in the anti-inflammatory phase. Inhaled budesonide, again a marginal role. Tocilizumab, doubtful role. Baricitinib, doubtful role. So we'll talk about COVID pathophysiology just to understand where to put what. So with regards to COVID, we have several phases. First is the early infectious phase, where it is there in the throat. The virus is in the throat. It can settle in that phase or it can just proceed further. There you can have fever, some kind of a throat pain. Some people have a lot of anosmia, a lot of smell and taste, etc. etc. Then we have a pulmonary phase where there is some kind of pneumonia. Then you have something called as hyperinflammatory phase, where the pneumonia becomes ARDS or patient becomes very sick, they go for multi-organ dysfunction. Now what do you do? In the viremic phase, obviously the body is trying to take control. The role is for probably antivirals or supportive care. You don't have any role for anything else. Next comes, and we don't have any antiviral to the date which kind of controls the virus in the upper tract. None of the antivirals, including your so-called repurposed drugs like Hydroxychloroquine or Ivermectin, none of them have shown any evidence in the early infection. Then comes the pulmonary phase. In the pulmonary phase, the body is again trying to fight against it. Most of the time, body wins. Sometimes the body is not able to do it, then they go into the hyperinflammatory phase. In the pulmonary phase, again it's going to be supportive care. A subset of patients who have progressive pneumonia may benefit from remdesivir before they enter into the hyperinflammatory phase. In the hyperinflammatory phase, the host immune response goes beyond what is normal. So the immunity becomes profound and the body's fighting response is so much, patient develops ARDS. This is because COVID is a new infection. The body has not had any kind of immune response to it. So the vigorous inflammation. That's when your anti-inflammatory drugs have a role. So if you give steroids in stage 1 or early in stage 2, it is going to increase the infection. Similarly, remdesivir in stage 3 is not going to work. So we need to use the drug judicially. Let me give another example. So when you categorize the infection into category A, B, C. A is somebody with mild, with young people, mild infection. B is somebody, B1 is somebody with high risk with mild infection. B2 is somebody with mild hypoxia. Who are on high risk? Patients who have end organ damage, patients who are on long-term immunosuppression. Because these are people who can go for stage 2 and stage 3 fast. Now, by giving steroids in stage 1, you are shifting a patient from category A to category B automatically. You are shifting somebody who is immunocompetent to immunosuppressed. In other words, we are pushing a stable patient to a sick patient. A subset of them recover, but we do see quite a few patients coming with early steroids with very bad pneumonia, very bad ARDS, very difficult to control. So steroid is not for everybody and don't try to give it in stage 1. I know facts are stubborn, but statistics can be more pliable. This particular episode, this particular epidemic has shown this more than anywhere else. So I will just summarize about the treatment option and then we'll understand the evidence behind it. Somebody comes with COVID infection, we divide into mild, moderate and severe. Moderate again we divide into B category B1 and B2. So mild is patients who are asymptomatic or mild infection, like those who have good saturation, mild fever, upper tract prominent. So they just require home isolation, some vitamins. You monitor the temperature. If they are really obese, maybe you can add aspirin. Or really obese, there is family history of coronary artery disease. Ex-smokers, you can run aspirin because coronary artery disease seems to be pretty high. Then comes the moderate category. Moderate category are patients who are symptomatic. You divide into category B1 and B2. Ones who do not have hypoxia, those who have hypoxia. They, category B1, we are talking about patients who do not have hypoxia who come under high risk. Like patients who have got things like coronary artery disease, renal dysfunction, COPD, somebody on immunosuppressant, post-transplant. They are relatively okay to see, but they have all these risk factors. This group, along with monitoring and giving vitamins, you can add aspirin and you can probably add budesonide inhalers. They may be a benefit if added early. Again, take it if added early. There is no role given in giving budesonide when somebody comes with oxygen saturation of 88 or somebody on high flow oxygen. Next comes to patients who come with mild hypoxia. These are groups where we give oxygen supplementation. We give them diuretics to maintain, or with or without diuretics, to maintain a mild negative balance. We try to maintain 300 ml of negative balance, somewhere between 200 to 500 ml. Just some negative balance will help. Anticoagulants, awake proning, and steroids. Steroids started early, around the time when somebody has mild hypoxia, benefits a lot. It prevents them from going into severe disease. There may be a role of convalescent plasma. We are not giving in Tamil Nadu anyway. Then we have Remdesivir. Remdesivir has a role in this group. Patients who are on the verge of hypoxia, especially with fever, they do really well with Remdesivir. Then comes with severe patients with real hypoxia, more than 4 liters of oxygen requirement, 4 to 6 liters, somebody on NIV, ventilator. Here there is again no role for Remdesivir. Oxygen is the only therapy here, along with your anti-inflammatory agents, methylprednisolone, dexamethasone. Here, if they come in acutely sick, we may give a higher dose. Tocilizumab may have a role in a certain subset of patients. So now, with this, I'm going to talk to you about the evidence for each and every drug, and then again, finally, we summarize. So we'll start with Remdesivir. So we have all heard about Remdesivir being 20,000 per vial. Yesterday, I saw counterfeit stock given to a doctor. Felt very bad about it. Is it worth it? Is it the life-saving drug? We look into the evidence. This is a solidarity trial conducted by WHO. Several centers across the world, they looked into several repurposed drugs along with that Remdesivir looked into. They didn't find any mortality benefit. It was in October 2020, where it was a huge epidemic abroad. Then where do you give Remdesivir? When patients come with impending hypoxia with fever. This group really benefits. For example, somebody has a borderline oxygen saturation with fever. That's when they respond really well. Especially patients with high fever going on for 4-5 days and borderline hypoxia, progressive pneumonia. This group immediately responds. 3-4 days, fever comes down, their hypoxia settles. You'll be able to wean off steroids by 4-5 days. Patients with mild COVID pneumonia may have a benefit. The best response in the first category, mild hypoxia or impending hypoxia. They're not even on oxygen because we keep a target of 92. They'll reach 92 when they lie down. That group only benefits the most. Most with patients with mild hypoxia may benefit. Third category is patients who are immunocompromised. When we told you the immune phase comes in around a week's time. By then the body's immunity starts taking over. We can't do much with antiviral. But there is a subset of patients where the immune phase comes in very late. The viral replication goes on for a longer period of time. They benefit even after probably a week or 10 days too. One is patients on active cancer chemotherapy, especially when they're coming in the immunosuppressed phase, 2 weeks or 3 weeks after cancer chemo, neutrophilic phase. Post-transplantation patients on severe immunosuppression. Even those who have got mild immunosuppression, the response to both vaccination and to your COVID infection, antibody formation is less. Next, somebody on monoclonals, rituximab, infliximab, less than 1 month. This group also comes in like that. You can also add things like post-splenectomy, patients who are on florid immunosuppression for some other reason. For example, somebody who's got a lot of methotrexate pulses, be careful with them. These are the groups which may have some benefit. Never use Remdesivir without pneumonia. And there is no role for Remdesivir if somebody is on NIV or somebody is on a ventilator, somebody who has got MODS. Remdesivir doesn't have any role if there is the meningitis or if there is any other end-organ dysfunction other than pneumonia. What is the evidence? We are looking into this ACT trial. If you look into this is a trial. You can see 4 columns. Column 1 is overall benefit. There seems to be a mild improvement. There is a mild improvement which is probably statistically significant. Who does it improve? Patients who have not received oxygen. I told you patients who are borderline, not the early COVIDs. Patients receiving mild oxygen, those who are not on ventilators or HFNC. Those who are HFNC also didn't benefit. So low oxygen requirement, not receiving oxygen with progressive pneumonia and mild hypoxia, these two groups, there's a benefit. So looking into it, patients who are on mechanical ventilation of ECMO, there has been no benefit. Remdesivir is superior to placebo in shortening the time to recovery in adults who have evidence of lower respiratory tract infection and who are not on ECMO or ventilator. So look into this. This chart shows us about remdesivir and oxygen requirement and no oxygen requirement. If you look into it, you can see Solidarity trial patient on ventilator, ACT trial patients on ventilator or NIV, Wuhan trial, all of these trials, when they gave remdesivir and patients on invasive ventilator or non-invasive ventilator, remdesivir made the condition worse or there was no improvement. Look into the remdesivir beta arm. You will see patients on no oxygen or mild oxygen, they had some benefit. Low flow oxygen, mild oxygen, especially low flow oxygen, they seems to be having a good benefit. So use remdesivir when somebody comes with impending hypoxia or mild hypoxia. So this is not a drug where you need to queue and get it from outside for somebody on a ventilator. It's not going to save lives in a very sick patient. It may have a benefit in hospitalization duration or may prevent progression. It's a small subset who go for mild hypoxia. So don't panic if you don't have remdesivir because it may not have much of a mortality benefit. So remdesivir helps in certain ways. So, but this can be extrapolated anyway, but statistics, when the fact is so clear, we should probably take it up. Next, steroids. So much on steroids. Everybody gets steroids now. We have patients taking steroids over the counter. In fact, there was one, I got it from Bombay High Court. Apparently, they wanted to see whether dexamethasone was an alternative to remdesivir. It went to such a level, we had some releases, even from government side, asking steroids to be given for a lot of patients. But remember, steroid is an immunosuppressive agent. It works only in the immune phase. If you give it in the viremic phase, you're making an immunocompetent to an immunosuppressed individual and they can progress much more fast. So be careful when you use steroids. Steroid indication. How much do you use? What do you use? You use either dexamethasone 7g or methylprednisolone for 5 to 10 days. When do you use it? When somebody has hypoxia, when somebody recovers out of hypoxia and or hypoxia suddenly becomes really sick. For example, somebody has been on 15 liters, you go down to 6 liters and suddenly worsens. It can be because of two reasons. Again, because of immune activation or because of infection. If it's immune activation, again, steroid helps. So generally, low dose is given when they have come present with hypoxia. And we give them a pulse when they have a sudden severe hypoxia. At that time, we always rule out sepsis and cardiac failure. Steroids should never be used without hypoxia, never be used to control fevers, never be used as an add-on to antivirals. What exactly happens outpatient is you give Fabiflu and steroid, doesn't work. Don't give it beyond 2 weeks without a proper indication. Generally around 10 days, maximum 14 days. Taper it, bring it to a minimal. Covid positivity is not a steroid deprived state. Don't give steroid just because somebody COVID is positive. So the trial which made us all use steroid is recovery trial. Recovery trial is a trial where they are looking into multiple drugs, one of which was steroid, and this is conducted across several centers. And so the validity is much higher. If you look into it, you have 4 arms. When you look into it, there has been a mortality benefit. But look into the various arms. One is all participants in box A. Box B is somebody on ventilator. There is a dramatic difference. Oxygen only, there is a difference. Then coming to with no oxygen, you can see there is an increased mortality with dexamethasone. Going to that, this is what the recovery trial says. Dexamethasone 6 mg, which extrapolates to methylpred 32 mg or prednisolone 0.5 milligram per kg, around 30 mg. Basically, we are trying to give 0.5 milligram per kg of steroid of prednisolone or methylprednisolone or dexamethasone. If you look into the arms, when somebody is on ventilator, invasive or non-invasive ventilator or receiving oxygen, there is a mortality benefit with dexamethasone. But if somebody receives it without oxygen, they actually died more. The same thing again, steroid without hypoxia can increase mortality. Please be very careful. So next kind of steroid which we've been using now is inhaled budesonide. This is based upon the STOIC trial. So basically, we are not looking into mortality here. They're talking about mild COVIDs. They're looking at mild COVIDs to prevent progression because that's what we all want. We don't want patients coming to our ICU. How do we prevent it? One, we were all trying to vaccinate them, avoid getting the infection. Then if you get the infection, anything to decrease the risk. How to decrease the risk? Control your sugars, make sure BP is on control, your cardiac status is perfect. Along with it, we are trying to do few other things. One of them could be budesonide. All high-risk patients can take 400 mcg of microgram of budesonide to inhalation 2 times a day from 7 days from the onset of mild symptoms. That is, the number needed to treat was 8 to 1, which is quite significant. Recovery is 1 day shorter. Here, they were not looking into mortality. They were looking into patients visiting the hospital or emergency. So, there was some difference with that. Time to recovery came down by a day and effervescence was a bit early and hospital ER visits became less. So, we talked about one immunosuppressant, oral steroids, and then IV steroids. Next drug which is costly, which is, I don't know, it could be an elixir or fantasy, but I know this becomes very costly. People are trying to buy it for a lakh. Nobody gets it. Well, again, I'm not really sure about it. I will just talk about 2 major trials and I'm just responsible for what I say. It's absolutely up to you to understand what you want. So we'll talk about the REMAP CAP trial, which brought tocilizumab back. Before that, we used it, we threw it away, and then we started taking it in. Tocilizumab was used along with dexamethasone over a particular subset in this subset in REMAP CAP trial. They used patients who had an acute progression or rather a hyperacute progression. These were patients who were hospitalized and became very sick very fast. That is, within 24 hours into the ICU or within 3 days into the hospital, those who progressed with minimal or no oxygen to high requirement of oxygen, including mechanical ventilator, NIV or HFNC. Make sure it is an acute progression. Remember, if somebody has been in hospital with you for weeks at a time, tocilizumab does not have any role. This can be given only when there is acute progression. So what they realize is there may be a benefit. In this trial, they also tried something called sarilumab, tocilizumab and control. We won't go into details. What is seen is, look into the picture A and B. So there seems to be a slight improvement. So if your patient has a sudden acute progression, which is an immune crisis or so-called cytokine storm, they may have a benefit. Now, let's look into another trial, which is again a huge trial called Impactor trial. They didn't find any survival benefit. So if you have a clear accentuation, like you choose your patients very well, don't leave out of it. There may be a benefit with tocilizumab. I'm talking about patients who acutely worsened. They need to have an acute worsening. Those who crash, that's a group of patients, and if you use it acutely, there may be a benefit. So I know we are still not sure about tocilizumab. It may be doubtful also, but be careful. Keep your fingers crossed. So with regards to tocilizumab, if there's an acute crisis, use it, but otherwise not much of a role. Again, if you don't get it, no need to panic because we have not shown any mortality benefit with this. Next comes, what do you do when patient acutely becomes sick when you don't have tocilizumab? This is a Codex trial. We have 2-3 trials on this. I've just taken up one trial, which is the larger numbers. So here they use dexamethasone 20 mg. Remember, 20 mg comes to 1 to 2 milligram per kg body weight. So this is a Codex trial. The other option is you can go for 2 milligram per kg of methylprednisolone. They gave it for 5 days, followed made it half for the next 5 days and then slowly went down. This is what we use in our ICU. We pulse them with a higher dose of steroids for 3 to 5 days and depending upon the response and then go down. So they had in these talking about patients presenting with moderate and severe ARDS. Here moderate and severe ARDS is not defined by CT score, it's defined by patient's respiratory status. So patients who are sick, who acutely become sick, were given dexamethasone and they had some benefit. So how do you immunomodulate? So when somebody comes with hypoxia, severe hypoxia, along with inflammatory markers being very raised, you use two conditions, severity of hypoxia and rapidity of progression. Simple way to go it. If COVID pneumonia patients comes with no hypoxia, no steroid, just supportive care. Mild to moderate hypoxia, it is dexamethasone 6 mg or 8 mg depending upon original molecule of 6 or 8 mg. If they come with severe hypoxia, look into the progression. If it's a fast, rapid progression, 2-3 days, patient become very sick means pulse them with dexa 20 mg or methylprednisolone 2 milligram per kg, 3 to 5 days and go down. Very fast progression, totally with methylprednisolone. If they are again progressing insidiously over days, 4 liters, 6 liters, 8 liters, then there is no role for these pulsing. Then you continue with dexamethasone 8 mg. Another thing which came in is baricitinib. Again, yeah, difficult to pronounce, but I know everybody is talking about it, but don't be surprised. It's just another repackaged stuff. So this is a trial which made it into all the books, Act 2 trial, a genuine trial, but there was one major problem. They used baricitinib with remdesivir. They used placebo with remdesivir. They didn't use steroids at all. By then, we knew steroids really work. So there was some benefit, but I think if you had used steroid, it would have been the same. So according to me, it's a costly drug, probably, getting the same cloth in a different 5-star setup. Beyond that, probably not much of a use. So I've talked about so many drugs. I didn't even think of talking about certain things because there's so many material available and literature is so much, but majority of them really doesn't make sense. This was a good article which came in Nature in May. They were talking about how COVID epidemic brought about so many papers, and some of them, even after knowing that it doesn't work, people persisted. One of the common things is hydroxychloroquine. I didn't put anything on hydroxychloroquine because by now we know it doesn't really work. You had nearly 250 trials on hydroxychloroquine, despite enough evidence saying that it doesn't work. Take up about Ivermectin. Again, quite a few trials, nearly 100 odd. And if you change the statistics, it will give an idea that it probably works. Convalescent plasma. Even after the recovery trial clearly said that it may not benefit, there are several trials. Favipiravir. Still on trials about tocilizumab, lopinavir, ritonavir. Well, trials happen. Despite probably knowing very well they don't work. Next comes now the new drug which has got into a lot of patients charts and probably in some thing is a colchicine. Recovery trial tried this and trial is terminated. They took in more than 10,000 patients. There was no mortality benefit by 1 month. They're looking into any other evidence. It's in preprint. So, but we know that it doesn't save lives. Whether any effect on fibrosis, I guess we'll get to know later. Again, it's used early. Imagine in the early phase of a disease, you're immunocompetent. Don't use any drugs which suppresses immunity. So personally, I don't believe in colchicine. Next comes the Ivermectin saga. I mean, it's more like a story now. Basically, Goa government decided to give it across to everybody. Then Karnataka government said, Uttarakhand government said, why did everybody decide this? Let's look into it. So Ivermectin is something which is used extensively in India without any rationale. Also in South America. I know it's a cheap drug. So after this came out, WHO immediately said that WHO recommends against it. And somebody pulled it up from MST. MST or the Merck, which has the original molecule, if they had known that the world will use it so much, probably would not have released it. MST had given a statement in February saying that there is no scientific basis for COVID use, for Ivermectin use in COVID-19. There is no evidence supporting it and we don't know about safety. This happened in February 2021 and we still believe it works. Now, what made people use it? It's basically because of this review. They said they've gone through 18 RCTs in a meta-analysis and says Ivermectin is a saga which works for everything, including mild, prophylaxis, moderate, severe. Well, when somebody says a drug can work on everything, please take it with a pinch of salt. They did it with statins, it didn't work. They did it with few other drugs, vitamin D, didn't work. So it's somebody's persistent view of pushing it across. So this, if you go into this trial in details, I'm not even trying to do it now because it's a lot of data. And you will notice that most of these trials were small numbers. There's no good masking. There are a lot of issues with the trials which have been used to say that it really works. So finally, we have enough material that Ivermectin doesn't really work. WHO has said This is one trial which came in JAMA in 2020, in March 2021. They looked into the mild COVIDs being treated with Ivermectin 12 milligram for 5 days. This is what across India it's being used. There's been no use. So ivermectin probably will help you get rid of your strongyloids, scabies, maybe any other parasitic infection, but probably it doesn't have any role in treating COVID. And when you take a higher dose for a longer period of time, it may suppress your immunity. You may even end up getting a progression. So be careful. Next, one question which everybody asks, I keep having fever. Fever is persistent, shall I take steroids? And I know a lot of physicians give steroids to control the fever. Do I need to do that? The answer is definite no. Because we have this trial which checked across. Again, is one of the trials from UK. They looked at a lot of people who were on NSAIDs for some other reason or who had NSAIDs during this period. They realized, like, look at the numbers, it's nearly 80,000. They didn't find an increased severity of COVID-19 with NSAID use. So you can easily take NSAID if your fever doesn't come down with paracetamol. Don't go for steroids in the viremic phase. Next thing, which the new drug which is on the horizon, which is colorful, everybody is talking about it, is the monoclonal antibody cocktail, the Regeneron. There are several ones. I am not even able to pronounce them. They're supposed to act in the early disease. So when you have a mild disease, you take this. It is given as an injection, as an outpatient basis. The monoclonal antibodies bind across to the spike protein and prevent severe COVID-19. Their costly effect on variants is unclear. There is a recovery trial on this. There are some trials which have come out which are all phase 1 and phase 2, not peer reviewed, so I'm not going to discuss them. It is something which is coming up, maybe a costly option, but for a subset of patients, your transplant patients, post-op patient may have a role. Let's wait and see. Finally, this is evidence with regards to most of the drugs used. Another thing which we see is vasculopathy, patients coming with MIs and strokes and peripheral vascular disease. Do we have an option? What is the role of anticoagulants? This is a trial where we try to look at prophylactic dose and therapeutic dose anticoagulation on patients who are very sick. What did they find? Not much of a difference. So your usual prophylactic dose should be more than enough because both the bleeding and clotting risk is increased with COVID. So give them anticoagulation, but give them at prophylactic dose. Once they are ambulant, for example, if they are very weak and tired, for 2 weeks you can continue with their oral anticoagulants, or 4 weeks. Once they are ambulant and moving around, just probably come down to your antiplatelets. Still, we don't have much material on antiplatelets, but most of us use it routinely for 2 reasons. One, most of our patients are high risk. Even if you take up the Framingham Heart high risk score, majority of them come under high risk. And second, follow-up is becoming difficult. So an aspirin or clopidogrel is used extensively, and I use extensively. So this is a subgroup analysis on patients with standard dose of anticoagulation with an intermediate or increased dose. You will see that standard dose is more or less what is needed. So we go with once a day anticoagulation now. So finally, coming back to what works in COVID infection, mild asymptomatic infection, use vitamins, monitor temperature. High risk, as per the Framingham Health Score, you go for aspirin. Moderate, if they're going to be high risk because of end organ dysfunction, maybe budesonide inhalers. If they come with hypoxia, moderate risk with mild hypoxia, may consider remdesivir along with dexamethasone. Severe disease, methylprednisolone, dexamethasone, proning, nothing else works. Epilogue again, no miracle drug for corona. The only thing which saves lives is oxygen. Remdesivir only in the viremic phase, that is, don't use it when somebody is on a ventilator. Anti-inflammatory steroids, use it only when the patient is hypoxic. No role when they do not have hypoxia. Inhaled budesonide, high risk group who can progress. Tocilizumab, baricitinib, think about it when there is an acute crisis. Oxygen, we are in short of oxygen across India. Please use it judiciously. Don't try to get to 98, 99. Steroids, double-edged sword. Don't use it in the viremic phase. Thank you.